break. So let's move on to the next session. Here comes the powerful concept of transformational impact of IT in healthcare. And for this, may I invite the panelists onto the dais. With a huge round of applause, let us all welcome Shobhana Kamineni, the Executive Director, Special Initiatives, Apollo Hospitals. Mr. Bob Kocher, the Principal McKinsey & Company, McKinsey Center for U.S. Health System Reform. Dr. T. Ramaswamy, Secretary, DST, Government of India. I request the panelists to please come onto the stage. Dr. Pervez Ahmed, Chief Executive Officer and Managing Director, Max Healthcare. Mr. Harsh Manglik, the Chairman, NASSCOM. Mr. A. Vaidheesh, the Managing Director, J&J Medical India. Mr. Rajneesh Rohadki, Head MMS BD. Mr. Dilip Kumar, President, Nursing Council of India. And Sir Moir Gray, the Chief Knowledge Officer, NHS. I request all the panelists to please come onto the dais. In no order of preference, I repeat the names. For the next session, the panelists are Shobhana Kamineni, Bob Kocher, Dr. T. Ramaswamy, Dr. Pervez Ahmed, Mr. Harsh Manglik, A. Vaidheesh, Mr. Rajneesh Rohadki, Mr. Dilip Kumar, and Sir Moir Gray. And ladies and gentlemen, put your hands together as we call on the stage Ms. Barkha Dutt, Director NDTV and a media magician who will share her thoughts and elicit views from the thought leaders of the world on this subject. Ladies and gentlemen, let us all put our hands together. Ladies and gentlemen, I shall now hand over the session to Ms. Barkha Dutt. Thank you.
Thank you so much. Good morning, everybody. As a journalist, I often travel into very strange and some would say even dangerous areas. As somebody who covers war conflict on a regular basis, it's interesting to me that in my life of 16 years as a journalist, bombs and grenades and guns don't scare me as much as a trip to the hospital. And I've often met doctors in hospitals who say to me, what kind of a paradoxical person are you? How come we see you out there in Libya or in Kashmir or in Iraq and you're not scared, but when you come into a hospital, you're so suspicious and paranoid? When I was asked, that wasn't a bomb, was it? When I was asked to moderate this session, I actually said that I'm here really to bring a lay person and a patient's perspective to this entire discussion. and to, in a sense, flag some of the things that people like me feel when we go into a hospital. Why is it a visit to the hospital mortifies us so much? I'm sorry, can you hear me?
No.
Are you able to hear me? All right, we'll wait for the sound system to come back and I'll start all over again. Are you able to hear me at the back now? Are you able to hear me at the back now?
Ma'am, till then you can use this microphone.
Are you able to hear me at the back now? Okay. I'll start all over again. I was just talking about the paradox of being somebody who spends a long time in conflict zones. I just recently came back from Libya and Egypt. I've spent a lifetime covering wars. But bombs and grenades and rocket launchers and men with guns don't scare me as much as doctors in a visit to the hospital. And every time I go to a hospital, many doctors are my friends and they'll always turn around and say to me, how come you're not scared out there, but you're scared of a needle? And when I was asked to moderate this panel this morning, I said that I would bring a layperson's perspective. Why is it that completely rational people feel completely insecure when they're inside a hospital? Because in the end, that's what patient safety is really all about. And so many doctors actually, who are friends of mine, talk to me about how they're extremely paranoid about taking decisions because they're scared that they'll be landed with some sort of medical negligence suit. But talking from the other side of the battle lines, as it were today, from the patient's perspective, can there be guarantees for what we are calling at this seminar patient safety? I think that's what we're here to discuss today. And I want to start with Sir Gray, if I may, who's the Chief Knowledge Officer of the NHS. First, I'd like you to talk a little bit about President Obama's statement that's caused a major stir in India, where he said that he didn't want Americans traveling to India and Mexico for cheap health care anymore. A lot of Indians sort of took offense at that and said, hey, we just provide effective health care at cheaper the cost. And is that something that we should include as part of patients' rights? The right to question whether they are, in a sense, being duped or overpriced? Sir Gray. Go ahead.
I think the key issue for the 21st century... Can you hear? Yeah. The key issue of the 21st century is to hear the voice of the patient. We will all be patients. Some of us are patients already. So I think when we look at the way in which we're looking at the future, we have panelists here representing various sectors, but perhaps you are representing the member of the public, the patient. And several points about the patient. Firstly, at least 5% of patients are better educated than professionals. Secondly, the decisions that patients face are relatively simple. You don't need a medical training to decide whether or not to have your gallbladder out. You need to know what's the probability of success and what is the probability of harm. And thirdly, I think we see that if the patient is at the centre of care, it's actually the most efficient way to run it. So that's my challenge, I think, is to look at the world from the point of view of the patient, because we will all be patients. But I think, as well as the moral reason, there's a very practical reason for taking the patient's perspective.
All right, Bob, you wanted to come in at this point.
Sure. So I recently worked in the Obama administration on healthcare reform and healthcare policy, and I think that comment should be taken with a sense of pride, actually.
That's
from
what
an
I
Indian
thought.
perspective.
Yeah.
We very much would like to emulate in our health system the reliability, quality, and productivity that's delivered consistently across many systems in India. And if you look at the variation which occurs in the United States and the variation that occurs in the NHS and other places, if we could root out some of that variation, we would do a couple important things. One is we would improve patient safety and outcomes demonstrably. Secondly, the patient experience of care would be less terrifying to you and to patients. And third, prices would be lower and grow less fast. And so that's really the central question that health systems and around the world are thinking about, and India has a big advantage. Right now, you're already doing, in many cases, extremely high-quality care, incredibly productively, at very competitive prices. And a challenge for India will be maintaining that advantage, and a challenge for the rest of the world is going to be emulating some of it.
Dr. Parvez Ahmed, if I could get you in now. When a patient hears the phrase patient safety, what they really want to know is simple things, commonsensical things. When they get an injection, is the needle clean? Is the needle a new one? Are doctors washing their hands before they're touching a patient? Is there danger? And in India, we hear this all the time about baby swaps, babies who get swapped in hospitals. There's also the more serious danger of there not being enough specific identification. In America, there's some hospitals that started palm scanners, for example, to avoid that kind of thing. In India, it's fairly common for two people to have the same name. We hear reports sometimes of the wrong side of somebody getting operated. This is what a patient wants to know, things like this, which when you walk into a hospital, you feel you should be able to take for granted, and yet there's always this lurking fear that you can't. Are hospitals paying enough attention to this?
I want to just take you back in a perspective of what healthcare was and what healthcare has become now. You know, healthcare at one stage used to be a very simple delivery system where there was a lot of trust between the patient and the doctor. It was a simple phenomena. It required simple things, and that's why there was very small margin of error. Now what has happened is that large number of people need health delivery. It's scalable. Lots of different people are in the process of providing health care in a hospital, and as a result, safety becomes a matter of concern and an issue. And I think that if, from a provider's perspective, if we engage on one simple, a few simple words, which is trust, right? When a patient selects a doctor, it is really because of the trust or the faith that they have in the doctor, that the doctor is able to provide what they feel that they can. So when they go to a hospital, they also expect that the same degree and level of comfort of the trust. So from a provider's perspective and people who run hospitals, we have to make sure that we maintain that trust. So whether it is infection prevention, whether it's safety in both for the employee as well as the patient itself, that it is provided. So, and I think that it's important. It's so important in India for us to actually report that, right? To measure it and report that. We don't. We should.
But if I can just give you an ordinary person's experience in any hospital, one of the things that you sense is that doctors are always so pressed for time. There's always more patients than there's time to see. And when patients have questions about medicines, when patients have questions about needles, when patients have questions about the hygiene of equipment that's actually being used on them, a doctor will either kind of laugh at them or indicate that they don't have time. I mean, this is something I think patients experience all the time. Is there actually a problem, very basic problem, in just the number of, the ratio between doctor to patient?
Well, that's the scalable issue. So what happens is that more and more people access healthcare and you have less people providing it. So as a result, you have to devise ways of making that, let's say, that the line work harder. It's unfortunate, but that's the reality of where we are today. And as more and more health insurance becomes available in India, the demand-supply gap will increase even further. But I think that the issue of safety should be a number one concern for the physician as well as the organization or the healthcare provider to make sure that wherever possible, we provide the safest environment, for a patient. And I think that's the only important message there.
Shobna, if I can get you in, I know that Apollo has, in a sense, a list of initiatives that it's started as part of a patient safety program. Among them is a simple thing that we were taught since we were children: wash your hands. Wash your hands before a meal, wash your hands before you look at a patient. I have to tell you, I have never seen a doctor washing their hands in hospitals. I've only seen that happening on medical soap dramas on TV. Do doctors actually wash their hands before they look at patients?
Absolutely. The TV's got it from what the doctors do. So it's not just
soap. No, seriously,
soap.
I've never seen it.
I think that washing your hands with soap is one level, but you actually have the antibacterial wash and we have them outside every patient room, and that the fundamentals is always, you go back to the basics and you'll find they're right, and everyone in this room will agree with me that that's a basic safety requirement. It's done, Barka.
But do you find that you have to enforce it? Do you find that a lot of doctors will feel like, I'm wearing gloves, I don't have to wash my hands, I put on my sort of medical gloves, so I don't need to do this?
Barka, that was kindergarten. They do it, and now you'll find that they move on, that the nurses are actually wearing gloves where they're, when they're administering the patient with anything. So they've kind of moved on from just washing hands.
Dr. Ramaswamy, from a governmental perspective, do you believe that patient safety can ever be a right that is legislated? Because, for example, is there even a consensus across hospitals as to what mandates and, is there a guaranteed set of basic minimums that a patient can walk into a hospital and say, if my hospital or my doctor does not give this, they have violated a medical ethics code?
Well, I think one should address this first from the perspective of a responsibility, more than the right. I think the responsibility is higher than the right, in my opinion. Right can take you to court, but responsibility keep you alive. Therefore, I think nobody is going to have a second thought, whether government or in the hospital health providers or the patients, that the patient safety is not negotiable. It has to be fundamental, and the government certainly is committed to that issue. And I believe when you discuss these in a larger goal, you can have any kind of legal framework and law and positions, but there's a culture and practice that will have to take place in much larger health providing systems of this kind, and I believe the government is fully backing up this bill.
But, for example, in India, we don't even have data to study how serious a violation of patient safety may be. We have World Health Organization figures, we have figures from the United States of America, which talks about 50,000 to 100,000 people dying from medication errors alone, another 100,000 from hospital-acquired infections. In India, we haven't even begun to process what the damage might be, and right now we're talking essentially of hospitals in urban areas. We aren't even talking about parts of this country where primary health care is not available. So do you believe that when you say that it's a basic right, patient safety, that we can even understand how bad or good or effective it is in our country without any data to study it?
Frankly, I cannot say that I have the data, but I'm sure people who are associated with this industry will have this data. When we discuss this issue in a broader perspective, I agree with you that we should have a risk minimization process without increasing the cost and burden to the individual concerned. Very often what happens, when you do the risk minimized healthcare management system, sometimes if you go beyond the threshold, such things can happen. But I think it is not in the enunciation of law and the right which is, in my opinion, the bottle helps to operate, it is the operational process. And I believe that with the kinds of developments that take place, kind of IT technologies that happen, there will be a considerable decrease in those concerns that you mentioned before.
But do you believe that there should eventually be a legislation for it?
Legislation alone is not enough. Legislation is necessary, but that alone, in my opinion, is not enough when you discuss these patient care issues.
All right. I think that raises the question, if I can get Vaidesh in now, that raises the question of how a patient, in a sense, enforces her or his right to safety in a hospital zone. Because there is no law to fall back on. There is, of course, the Indian Medical Association that may be overseeing it, but if you do not have a legislative framework, and I'd be interested in knowing how this works in other countries, but if you don't have a legislative framework, what do you do when you feel that something completely violative of your safety rights has taken place?
Barka, I think first thing we need to recognize, I think the healthcare community, deliberately, I don't think they will compromise on patient safety. Now, I think based on my interaction with the ecosystem of either it's a doctors or a hospitals, I think they are committed to figuring out how to get the best patient outcome. The fundamental issue which tend to happen is that I think in India, we have a varying standards of care. We have islands of excellence where you have the highest level of infection prevention protocol, they follow the world-class standard. On the other end, you have standards of care which is from no care to some care. Now, what's very important is that the patient, when they go in, they trust the hospitals to deliver whatever is supposed to be done. Now, in an urban center, you find there are patients who read the internet, there's an awareness that has come in, they go and challenge the doctors even before they go for a surgery. Now, you have on the one end. Other end, people absolutely surrender themselves. So what we need to do is that which we don't have in this country, I think we need to have a certification of the healthcare professional on an ongoing basis. Now they started an MCI guideline has just come in, the recertification is becoming training. Once we do that, you will find the standard of care dramatically improving. So far, we never had this scenario where the communicable disease was the primary important, now the non-communicable disease come in. So the new paradigm has come in. I think MCI has taken that control.
So you're saying that it's more a preventive sort of approach than a legislative approach in a sense?
Absolutely. Through training and awareness, continuous training, every year recertification, certification.
But you know, Rajneesh, if that were put to patients, I don't think they'd agree.
Yeah,
I mean, and you know, in India you always hear these horror stories of, for example, medical waste that lies outside hospitals that's uncleared. While we take syringes being cleaned for granted, we often find that they've been recycled and reused.
Yeah. I think, I mean, the syringe example that you said is something that BD has been extremely associated with. And we have found that, I don't know whether you want to call it legislation or as a policy decision, somewhere in between the two would have a role in play. For example, the entire immunization program of the country used to be conducted by glass syringes. And BD along with IAP built a partnership which really convinced the government to move to auto-disabled syringes. I think the fundamental problem is, unlike many other products, in healthcare, the product is created and consumed at the same time. So you don't have a quality control department which can prevent a defective product from reaching the customer. Even in a restaurant, the chef can taste the food and stop it. But here, the patient experiences as it's happening. So quality is dependent on literally the last mile, you know, the copper end of it, where the quality of the nurse, the training issues there, the constant attrition, and there are a whole lot of issues to do with saying what is the profile of nurses which are coming into the profession. Can it be a more respected profession which attracts better talent into it? What are the barriers to that? And there's a lot of work that BD has been doing in sort of helping create capacity for building the training capabilities in terms of either absorption of technologies and executing it well. One principal point that we follow is, can devices play the role of taking variability out of the practitioner's skill? For example, an auto-disabled syringe, it locks. Whether it's a 20-year experienced nurse or a rookie nurse, doesn't make a difference. Whether the attitude of safety and the culture of safety is well entrenched, or the person wants to reuse, it's taken out of her hands. So that's, I think, some of the areas to look at. Training, and I would agree with him.
So you're actually saying that technology can eventually replace human care?
I don't think it can replace, it can help take the variability out. Just like automation in a cockpit in an airline can help take some variability out and individual variations. It can help in standardized.
I do understand what you're saying, but I must say again from a patient's perspective that the psychological need for human reassurance is very strong to feel safe. And that's my perfect cue to go to Dilip Kumar, who's the president of the Nursing Council of India. And I think in the end, even more than doctors, it's the relationship between a patient and his or her nurse that really becomes a very crucial relationship, because that's the constant presence in the room, especially in patients in hospitals. But nurses are also always overburdened. I mean, I can tell you, as somebody who's watched an aging uncle in hospital for many, many days, I would feel paranoid about which nurse was with him, who was looking after him, did she care enough, could I trust him with her, would he be safe, would she know what to do? One of the things that you always worry about is, will the nurse know what to do, or is it some approximate sort of training to substitute for the doctor?
I think we have a sound knowledge is given to the nurses. The nurses are the key people in the healthcare delivery system, and especially they have given a course of instruction of all the patient safety which they have to perform in the hospital, and more so they have to spend time with the patients, because a lot of questions which the patients and patient relatives are going to ask. And now with the advent of this internet, I think any patient which is coming to the hospital, they are having a total knowledge about the disease process.
But I can tell you that every time you quote to a doctor from the internet, they get vastly irritated, because patients tend to believe they already know more than the doctors, and it's kind of half knowledge.
But at least we have to assure them,
Yeah.
we have to clarify them. I think that is where the interpersonal relationship between the nurse and patient, which is going to play an important role. So therefore, I think a nurse who has been trained, we cannot take it for granted for she has been trained forever. The constant updating of the knowledge and the skills, where the training
So you don't believe that technology can take away from the human fallibility
No,
as
no,
is being
impossible,
suggested here?
impossible.
Impossible, says Dilip. Rajneesh, we'll come back to you on that. Before I come back to Shobna, I just want Bob and Sir Gray to come in on this business of how the absence of legislation compares from country to country. Bob, to you first.
Well, thank you. A couple comments that I want to pick up on a few themes.
Just hold that a little closer to you. Just
Sure.
hold the microphone.
So first, I think we think about safety wrong. As I listen to your questions, you're talking about kind of the terror you feel as a patient. And we as providers talk about sort of the steps we take to make you not feel terrified, but you feel terrified. I think one should think about safety more as not how to avoid harm. Most of the discussions about how do we avoid harming a patient, as opposed to how do we make sure we deliver consistently the best outcome possible for a patient. If you focus on the outcome, on what success is like a year from now, you will take all the steps in the process to be safer. The second thing I'd say is you actually know more today in India and in most countries about the restaurant in many cases than the hospital or the doctor, and that's a data problem. That there might need to be legislation or regulation or some sort of compulsion to put out more data. We know that doctors and nurses and hospitals are incredibly competitive. When you put the data out there, you get much less variation and you get better quality. And so I think you need to get a market of data, and then there'll be a market that helps people consume that data, both providers to be better and patients to know what questions to ask. And the third thing is, while technology will not replace the doctor or the nurse or the team, technology is needed to have the team work effectively together. There's big misses of information between the doctor, the nurse, the outpatient team. In the future, there will be many more teams delivering care for more complicated patients. So you have to have technology, and technology also around safety. These locking syringes are life-saving changes in technology that are cheap and better. But the last thing I'll say in your question on legislation and regulation is, in the U.S., we have a lot of legislation and regulation, but we still fall far short on patient safety. So there's no explanation that says that legislation makes the system work.
Makes the system safer in a sense. Yeah.
That said, it is important to have some way for patients to be able to get the information, which legislation can help with, and when the system goes awry, to have patients be able to recover sort of for the harm.
That's an interesting question, and I will put that to both Dr. Ahmed and to Shobna. But Sir Gray, if you just want to come in on this business of whether, the point Bob's making is that a legislation doesn't make the system safer, but the point is also being made that patients need to know what they're entitled to when they go into a hospital. So should hospitals perhaps have a displayed, basic rights charter? Just to put an idea out there, that a patient walks into a hospital or is able to log on to a website and know that if they see a doctor not doing A, B, C, D, they can actually ask for it.
Right. Barka, I'll step back a bit in terms of the hospital itself. The hospital must have that eureka moment where quality is everything. And I think that happened in India. We got pushed, pulled, and all the other hospitals realize it, and that's why we have 500 delegates today, is because hospitals like Apollo adopted JCI, and I think that was our eureka moment.
But how do you publicize it to a patient?
We have 1,000 things that you have to fulfill in JCI. 50% are to do with safety. So the patient knows that when it has that accreditation of a JCI or an NABL, that you know that these hospitals have a certain level of quality. Now when it comes to patient rights, that education is something that part of JCI mandates that you actually put it out there, saying that a patient is encouraged to ask questions, a patient has rights, and this is part of the process that you'll see when you walk into any Apollo or Max or any one of our hospitals that actually talk about patient rights.
But let's talk about medication errors, and let's start with something we're now overusing, antibiotics. And I can tell you that most people in India are now not even waiting for their doctors to prescribe antibiotics, they're prescribing themselves. You now have Augmentin. I was saying to somebody this morning, you now have Augmentin like you have Crocin or paracetamol. It's that common. Or you call up a doctor, you say, I have a sore throat, I'm having trouble breathing, and they'll say, oh, start a 3-day course of Ceftum. I can't tell you how many doctors have told me this. On the phone, no prescription. Is that a medication error? Is that violating my patient safety rights?
Certain hospitals have different definitions of medication error, but I think it's a very scary issue, because let me flag that, being probably the only drug dealer in this lot here, is that the government is actually talking about that, we're giving antibiotics without prescriptions in pharmacies, but there's a certain list which is moving into the Schedule H that we have to start that we have to keep the prescriptions for it. So when you treat it like that, that's good, and hospitals themselves, all the hospitals here understand that it takes, for a hospital acquired bacteria to evolve, it takes 24 months. To get a new antibiotic on the market takes 6 years. So now do you understand what a scary situation? And everyone in this room, if you ask them what is the single scare that you're going to see in the future, it's no longer the bogey of H1N1 or AIDS or any of those old infections, but it's really what is it that you can acquire, and what are the new bacteria that are growing that the antibiotics we have today will not be efficient enough to treat it.
But Parvez, not to sound skeptical, that's my role here today. It's one thing to say that all pharmacies should give prescriptions. We all buy medicines without prescriptions. We all know our neighborhood pharmacist. Often you need medicines where you don't need to go to the big shop, you don't need to go to the hospital. You can walk out of your house into the same, and your pharmacy will be next to the guy who sells you bread and milk. You've known him for 20 years. If you want a medicine over the counter without a prescription, you'll get it. Isn't this more scary thing how trigger-happy doctors have become about prescribing antibiotics? They prescribe like they're chocolates.
Let me try and attempt to answer that question, only because I guess I'm part of that profession. And I think all of it, if we bring it back into the concern of safety, has to do with what is called patient-centric care. And what was mentioned, which is very important, is that we must see whether the outcome is what we want. And are we providing value? So if the question is that should every viral infection get antibiotics, the answer is obviously no. And so there has to be knowledge, there has to be competency. I think the prescribing habits of clinicians need to be reinforced, that the correct antibiotic should be used for the correct bug. The good thing or the bad thing is that bacteria have been here before we got here, and they'll be here after we've left this universe. So they have a remarkable ability to mutate. So if we are not smart about that, as to how we prescribe, and the pharmaceutical industry doesn't spend its dollars in research, we're going to have more and more resistant bacteria in the world, and that's what's going to happen. So if that is a safety issue, and I believe it is, and not infection control, I think we should call the term infection prevention, which is probably more important than control. Controlling means you first provide the infection, then try to prevent it, or control it. It's better to prevent that infection from happening. So, and that requires education. It requires some degree of regulation. It requires some significant amount of oversight. because the law is there. A pharmacy cannot dispense a medication without a prescription, but somebody has to enforce it. And I think that requires, I believe, a little bit of government or judicial, oversight, if I could put that. Yeah.
Can I go to Dr. Ramaswamy and discuss something that seems to divide the medical community in India, which is the superbug? The superbug, which has returned in a sense to haunt the debate here. We began with a lot of nationalist chest beating, saying this was an insult to India and so on, and it was a way to stop patients from coming to India. That's the same reaction we've had to President Obama's statement. But looking beyond business, do we need to look within and actually look at hygiene and look less defensively at this whole debate around the superbug?
Well, ultimately, the government has to serve the people. There is no two opinion about those. These issues, if it is motivated, then we have to address in a different way. These issues have to be addressed and solve the problem, that's another way. It is true that the public hygiene and the health conditions in large urban cities, metros of our kind, need to be improved. There is no second opinion of that process. I am aware that there have been two different opinions about this superbug.
The New Delhi bug. At least it's not called the Hyderabad bug.
Therefore,
but anyway.
It doesn't matter. I think we
So
have.
but has our response been defensive? Do we approach the gaps in our medical safety provisions and confuse them with nationalist pride?
Look, as far as this particular issue is concerned, they have mounted a campaign to actually find out and quantify and risk assessment at the moment. There's going to be a huge campaign. This is not just about the bug, this one particular bug. We have to learn from this experience and plan ahead. This question of drug-resistant bacteria or any kind of this microorganism has to be addressed more holistically than in a compartment form. Forget about the defensive or offensive issues. If there is a social practice to go to the pharmacy shop, you and I ourselves, don't go to the doctor and get an antibiotic prescribed to ourselves, and then say you have a regulation.
Yeah.
I'm going to quote Mahatma Gandhi.
Yeah.
He says, if there's a very small percentage of the population deviates from the regulatory practice, then the law enforcement will work. If a very large percentage of the population deviates from that regulatory mechanism, law will not work. It requires education, it requires a more holistic societal participation.
I've understood that, yeah.
Therefore, as far as this nuclear bug is concerned,
Yeah.
I agree with you that we should not look at it defensively and say, no, what are we saying? We should go and address it more holistically and address the problem.
Sir Gray? Yeah.
Lancet came out with that.
You see, we have to look at the public belief about healthcare. And many people criticize the media for hyping developments. But actually, it's the scientists and the journals. My experience in England, I set up a web service called Hitting the Headlines, where every day we analyse the headlines in the newspapers and television. But actually, the journalists are doing a good job. It's the scientists and the journals who are promoting healthcare as being something in which the good is terrific and the harm is minimal. And we're seeing with this particular problem that members of the public need to understand that all healthcare does harm as well as good. And we should be more cautious that more is not necessarily better. So the most important thing is to have an appreciation of the balance of benefits and harms. And I said yesterday, when we were discussing what we call people, are they patients or consumers or clients? A doctor said to me, well, they're punters. They're taking a chance every time they come into the health service. So I think we need not to blame the media. and not necessarily to blame the frontline professionals, but the scientific establishment and the journals need to present a much more balanced view of benefits and harms. And in the next century, we will see an increasing concern about the harms of healthcare as well as the benefits of healthcare. And that would be an honest discussion that members of the public are quite able to take sensibly.
I just want to bring the others in now. Rajneesh, if I can start with you. There are a few hospitals, for example, in America, which have started the practice of actually producing data every year about the mistakes that they've made, acknowledging errors that were made by the hospital. I mean, are we ready for that sort of transparency in India, and should we be?
In terms of data available to the patient or to
or an acknowledgement,
self-regulation?
an admission every year, a kind of internal audit, as it were, because since everybody seems to believe that legislation is not the answer.
Yeah.
But I think that perhaps would patients trust hospitals more where you see a list of the mistakes, or would you kind of say, oh my God, they made all these mistakes, I'm not going, not understanding how, you know, in the end, being a doctor has to allow for some space for human error.
So if I can split that into two parts. One is data available to either the government or a industry self-regulatory mechanism that the industry could look at as one part of the issue. And the other is whether the data is accessible to patients also or not. The former, most certainly, I think the time has come for the industry to come together along with the government to form a data bank which really starts providing and analyzing the trends and what needs to be done to address it. And that's something where the problem is that each of the hospital groups, I think, have evolved their own softwares and their own methods of measuring data with different definitions and different denominators. So the data probably doesn't even talk to each other from two different hospitals. So there is a need to standardize that and then put in place a national data bank. And I think NABH yesterday made a presentation on the importance of creating a national data bank there. When it comes to patients having access to it, that something is not an easy answer, and we in BRI have debated it for the last 3 years, ever since we started working on patient safety. And we debated what is the role of media, and if I can actually turn the question back on you in terms of role of media and propagating it, there has to be a sense of responsibility on when you communicate this to the patient. It's okay for the top tier hospitals who have reached the world-class standards to say, yes, we are okay with sharing the data, but the 95% of the healthcare delivery is such that the last thing you want is to create a feeling of helplessness or a scare among the patient.
So you're saying it could trigger alarm?
It could, unless it's timed in the right way and communicated in a manner which is making the patient involved. See, the problem in healthcare, unlike other categories, is the patient is not able to judge for himself. You go to a Kodak shop and get a set of films printed, you can see whether the printing quality is good or not. You get an X-ray report in your hand, you cannot double guess. So healthcare is a little bit of a black box. And in that context, there has to be that element of trust which was mentioned earlier.
Parvez, would you agree with that? I'll just come to you, Vedish, that we're not ready for this yet, primarily because a patient is not an expert at being able to gauge those admissions or that kind of transparency, that it could trigger greater alarm, it could trigger a deeper sense of paranoia. On the other hand, some would make a very compelling argument for the fact that more information can never be a bad thing.
Oh, I agree with you that more information is a good thing. But then how that information is used and supported are two different things. And I think we are quite far in India to have a transparent, similar, repetitive reporting system. So what can happen is that then patients and industry might use that information, or government might use that information to actually not improve. Yes, that's right.
Harass you is what
correct. Not improve, but actually create or improve litigation, stuff like that. So we have to be very careful in this thing. But I'm always 100% that there should be transparency, there should be accountability, and it should be a platform which I think eventually patients or public should have access to, in terms of how good or bad, let's say, an institution is or a healthcare provider is.
But then how? How do you find that middle ground, Shobhna, where you don't alarm the patient, you don't trigger a series of lawsuits, which is what seems to be being suggested here, but you give the patient a right that there should be some sort of industry standards of self-regulating mechanism which actually compares hospital to hospital and maybe grades hospitals for the number of violations they have of a patient safety code. I mean, could we see something like that in India? wherein then the patients would know. I'm saying a kind of internal industry grading system of hospitals for how well they keep patient safety in mind and implement it.
Barka, I think that is non-negotiable. And one thing is that you can't say that no hospital is going to have an error. This is going to happen. And the processes that you set in place that will reduce that is going to define the best from the also ran. And as we walked in today, I think that I heard a comment saying that it's not just, the people here, it's almost like preaching to the choir, because all of you have started this journey of quality, so you get it. It's how we can make the 50-bed, the 70-bed nursing home actually get into this, and while doing it, still continue to be profitable. I remember in the early days when this JCI was coming in, I was probably the only one hesitant at our board, because I said, and again, we're very doctor-driven, so we take some decisions that are not shareholder-friendly. But having said that, we said that what is the impact on the bottom line of having a clinical pharmacologist study every prescription, of having the nurse change her gloves 500 times a day? All these things, would it have an impact? And I think that I'm proud to say today that I was wrong. And I think that hospitals that have adopted this quality have actually been able to translate that into better service, again translated into actually the hospital having a better bottom line. So once everybody starts getting that message, that's automatically going to create a ripple effect.
Vedish, what I'm getting a sense listening to everybody is that in a sense trust, like with all other institutions, is about experience. And a patient's belief in a hospital or a doctor is in the end a word of mouth relationship. It's not so much that you need industry grading, but that people will tell people, hey, that's a great hospital to go to. Things don't go wrong there. That's a terrible place to go to. But is that enough? Is that enough? Or, because I have put this idea on the table that if there is going to be no legislation, should there at least be a self-regulatory mechanism for the medical profession in India? A kind of ombudsman. Like in the media, we too say that we will not accept government legislation, but we will create a broadcasting association where complaints can go. And I know that there's the MCI and I know that there's the IMA, but should there be bodies where ordinary people can take their complaints, or bodies that can be the arbiters of quality, recognize hospitals for quality and transparency?
Yeah, this particular question has been discussed by various industry leaders, and we have been at it for quite some time. In fact, recently I'm part of the jury of the Healthcare Awards. Now, how do you recognize a healthcare provider without having a morbidity data, mortality data? You don't have the outcome data today, we don't have. But very interestingly, you will realize there are large number of hospitals in India. They have something called the review boards. Every Tuesday or every Wednesday, these professionals meet up along with the directors. They discuss about the outcome data, but that's very confidential. They discuss it primarily to make sure the outcomes in the hospital. So you would realize there are a large number of hospitals who do this practice. Because of the fact we do not have a regulation the way in which you have probably in advanced world, where the data has to be submitted, so that you are graded based on your outcome data, on health economics data and all those stuff. Now, is there a need for doing it? Possibly, but you have a large number of small hospitals.
Yeah.
It's going to be a mammoth task for doing it. The one way to do it is that there are associations, NABH that has been formed, as an industry.
Doesn't somebody need to do it? Because that's exactly the point. There are small hospitals and big hospitals that are under no one's radar. They're not under the government's radar. They're not under the MCI's radar. They're not under the IMA's radar. And just because there's so many, we're also a billion-plus country. I mean, who's looking out at the quality of these hospitals? That's a thought I'm just going to park. I want to ask Dilip to humanize this discussion a little bit and to tell people like me, where is the area where the biggest errors take place, according to you? Of course, unintentionally, but what's the area where the biggest mistakes take place that we really need to be careful about?
No, the biggest, there are so many levels. It is not only one biggest area of error we can say. There are at different levels. At least when it comes to the nursing, there is every possibility of that. Nurses are mainly, they are giving the medication. Sometimes the medication error comes from the nurses. So therefore, we need, I think many of the errors which are taking place mainly because of we don't have optimum nurse-patient ratio. Because
don't have optimum nurse-patient ratio. Okay.
So that makes them, one nurse is looking after the 30-40 patients, and definitely, and she has to do we don't have in many of the government hospitals even the ward clerks. So she has to do the housekeeping, she has to take the inventory, and also she has to take so there's a lot of work.
So the nurse is overburdened,
yes,
and the nurse is more likely to make mistakes,
yes,
get medication mixed up, forget basic things because she's just so strained. Parvez?
Well, actually, this is an ongoing problem in healthcare, right? And it has to do in the fact that every institution, every provider has to embrace quality as a given. Right?
But what do you do with a basic gap like this? The one nurse to 40 patients.
Well, it's a problem, right? So the problem is that we have a resource issue problem, and I think, but there are some areas where we perhaps can make a difference. We can start writing orders which are in capital letters, so the transcription errors become less of a problem. We can use basic, let's say, electronic systems to actually record. These are little things which will probably help, because I don't know what the data is in India. I do know what the WHO takes out and says 1 out of 10 people have an adverse event when they enter a hospital. So I suspect that it should be not. It can't be better, it could be worse, or it could be the same. And I think the most common single error which happens in a hospital is a medication-related error. Whether it's a transcription error, so the wrong drug is given, or it's an error where the wrong time the drug was given, or that there was an adverse event, or the wrong patient got it. And all of it, most of the times it's about communication. So if the communication process is created such that the likelihood of that error is reduced, then it won't happen. And while it is quite clear that manpower plays a role, but you can have a lot of people, they can still create the same error if the systemic problem is
Fair
there.
enough.
And
The
I think
numbers alone will not
correct.
solve it.
So I think that it's the adoption of a process which is, as had been mentioned earlier, which should be outcome driven. So that means we should know that the person, if he writes aspirin, it is aspirin and not some other medicine. Because that's one of the common errors which happen in any transcription, and I think that's an issue here.
All right, I've got about 5 minutes left, and I wanted to take a couple of questions, but two brief questions to Bob and Dr. Ramasamy. Dr. Ramasamy, we've got the UID identification project coming up in India. Is that something like, for example, the social security numbers in the United States of America that will at least minimize identification issues for patients in hospitals?
It will. Of course, there is a problem with the privacy law.
Yes, that's an ongoing debate as well.
Yeah, and so I think if we merge it together, this certainly will.
Okay, so as that debate gets resolved, Bob, quick question to you. We know that President Obama put so much in his healthcare initiative. One of the big debates ongoing in India is that a number of private hospitals are now mandated by law to have a section of their hospitals look after poorer patients. But at what point do people have to feel that they have to pay for the quality of healthcare? Because, free healthcare in India, for example, means very little if it's not good quality healthcare.
Well, in the U.S., every hospital, regardless of being for-profit or not-for-profit or publicly run or not, has to take care of any patient that comes in the door for any emergency, regardless of their ability to pay, and they're actually not entitled to get paid necessarily for emergency care. I think it's very important that you have access and you have ways to give access. But together with that, to your question around quality, I think the best way to improve quality most quickly is actually around transparency. So I hear all around the world people say healthcare is a black box. Well, it shouldn't be black, it should be transparent. And while I don't need to know how to fly the plane, I need to know something about the quality of the plane and the safety of the airline. Well, I don't need to know how to make the food at the restaurant or even have the skill to taste it.
But I need to know that the ingredients are clean.
There's nothing that would, I think, do more and more quickly to improve the level of patient safety and quality in India than to make the data public. There will be people who help people interpret the data. There will be a tremendous market among hospitals to improve on the data. And the competition really should be around the quality and safety of care delivered and the outcomes achieved, not your impression of trust of the doctor or the location of the facility. It should really be data-based. And you'll have a much better market, and you'll have much more improvement more quickly with transparency.
Well, I'm being told that there's no time for questions now because I think we're expecting the Chief Minister any moment. But just want to close with something that I think, Parvez, to pick up from what you said. I can tell you that when people walk into hospitals, people who are not doctors and people who know nothing about medicine, they want people to speak to them. You know, there's that old cliche about bedside manners, and then you hear about great doctors who have terrible bedside manners. But I can tell you that human beings in the end will never feel safe unless doctors have time to talk to them. And I sometimes think we can have as many seminars as we want to on antibiotics and charter codes and data, but if there aren't enough doctors and nurses, one is a resource problem, but the second is a communication problem, and it all comes down to that. But in the meantime, apologies for not being able to take your questions, but a big round of applause. I think we flagged some important issues today. Thank you so much.